Yeah, so we're going to skip this one and we're going to go to planning on the... Okay, so what we wanted to run you through here is just in real time planning of a knee replacement. So I just want to walk you through, if we look here, this is the patient's native anatomy. So this is the first thing that I look at. So in this patient, the patient has 2.8 degrees of varus of their tibia, 1 degree of varus of their femur. Okay, so then we go to the plan, and this is all done before I ever get into the operating room. So one of the advantages is that you can get partway there before you even get into the operating room. So if a plan comes in where 0 varus here, 0 varus here, the first thing that I'm going to do is adjust my tibia to get to that 3 degrees of varus, so where the patient's native anatomy is. Okay, so you can keep going forward now. So now if we go to our soft tissue balance screen here, so now we do our exposure, we put our arrays in, and now we do our soft tissue balance. Okay, so we do that soft tissue balance, and we can see that this knee is very loose. Okay, so we're loose in extension, 4.5 millimeters loose on the medial side, 6.5 millimeters loose on the lateral side. And if we look in flexion, oh, perfect, thank you. So if we look in flexion, we're a little loose on the medial side and a little tight on that lateral side. So the question becomes, how do you then balance this knee? So what I would do when I balance this knee is the first thing I would do is cut a little less tibia. So we're going to move that tibia proximal a little bit. Okay, remember, moving the tibia affects flexion and extension. So we're going to take that, that's far enough there. So now we're going to move the femur a little distal. Right, so we're going to close down the extension gap now. And now this knee actually had, if I remember correctly, I think it was 2 degrees of hyperextension or 2 degrees of flexion. So this knee, yeah, this knee started with 9 degrees of hyperextension. So this is a knee that we're actually going to want to tighten up a little bit more. So we're going to move that femur even further distal to keep going a little tighter. And one more. All right, so I would probably leave this knee tight here because I want to get rid of that hyperextension. But then I don't want to leave it tight in flexion. So now I'm going to move the femur anterior to loosen up the flexion gap until we get to 0.5 millimeter on the medial side. Okay, and now I'm going to pin the femur here. So you can pin this wherever you want. It doesn't just have to be pinned centrally or along the medial side or the lateral side. And now we're going to internally rotate the femur. So the medial side stays the same, and I'm just loosening up that lateral side. So we'll keep going, just as an example here. Keep going, keep going, keep going. This looks like a lot, right? So now move the femur one more click anterior. And now you can see where our anterior cut is way anterior here, so we're going to downsize this to a size 1. Okay, that makes that in. So when you downsize, it takes all of the size out of the anterior. It doesn't touch posterior at all. So now this looks pretty good in flexion here. We've tightened up, especially that medial side in extension because we've got that hyperextension. Can we just run through our CT slices and look at where our trochlea is here? So now we're going to run through and we're going to see where the trochlear groove is. Yep, so now we're going to lateralize there, perfect. Exactly, so we've now lateralized that implant so that trochlear groove is where that native trochlea is. Even though we've got 4.5 degrees of internal rotation, can you just add the posterior condylar axis here? So you can see that to the posterior condyles, we're pretty neutral, but we're internally rotated 4.5 degrees to the epicondylar axis. So the power of how you plan here, this is what really takes time to learn when you're using a system like this. And this is whichever system you're using. But you can see where the trochlea is here and what you're doing with your flexion gap balance. I don't know if people have questions about balancing the knee. This is one of those things that you really need to kind of practice, play with, and do multiple cases to get good at. We just wanted to show you in real time. And then you can adjust your tibial slope as well. We talked a little bit about that. So you can really adjust things in all dimensions.
Yeah,
we'll leave it at that.
That's really very important to understand the planning. And as they say, if you've planned before, you don't have to think while doing the surgery, and then you save time there also. Because if you do the planning real time, then that takes 5-7 minutes more. So I think this is a great tool to have, and he just showed you, if you use it more, it's going to be more simple, and you're going to really be time neutral with what your conventional knee replacement is. Any questions? Yes.
One question, sir.
Good evening,
So,
sir.
so when you took, sorry.
How much of internal rotation can we plan in that? What is the cutoff for that?
So I don't have an absolute cutoff. I would say I get concerned when it's more than 3 degrees, but really what I want to see is that the native trochlea matches with the implant trochlea. That's what's most important, but I get concerned if it's more than 3 degrees.
So I just had one question, sir. When you were trying to do it, the flexion was 4 degrees, and the implant was little away from the anterior. So why didn't you decrease the flexion? And
so you can do that as well, right?
Yeah.
So you can play with it. You can. I think with how anterior that was, I'm not sure that getting rid of that flexion would have been enough. So we downsized to a size 1. But so one of the things that you can do with a system like this is you can adjust in all different planes. Where with mechanical instruments, you really don't have that option. So you can decrease the flexion, you can increase the flexion. If you're using a PS post, then you have to be concerned about how much flexion or extension, because if you come out into full extension and you've got, and your knee, your femur is also extended, then the box is going to hit the front of the post. So you've got to be careful with that. If you don't have a post, you don't have to be as concerned with that.
yeah, thank you, sir.
Yes, any other questions? This is your last chance to ask. We'll be finishing in a few minutes. Yes, please.
So, if you're going with this pre-resection planning, and if you have a tight varus and a fixed flexion deformity with posterior osteophytes, and you're planning with a pre-resection planning, how do you go accounting for the increase in the extension gap once you clear the posterior osteophytes after you have your cuts, or do you cheat it with keeping the gaps less in extension?
Yeah, so that's a great question, and again, it's kind of one of the benefits of the system is you can actually do a workflow that's called a mid-resection rebalance. So what you can do is take minimal cuts at first, and then just enough so that you can get into the knee and get rid of the posterior osteophytes. And then you can with tensioners or laminar spreaders, whatever you use, you can remeasure your gaps in flexion and extension after you've removed those posterior osteophytes, and then make your final adjustments to your implant position to balance. So I do that in probably 20% of the knees that I do. So if there are large posterior osteophytes or big deformities, I'll do that mid-resection rebalance. If it's small osteophytes, small deformities, I don't think you need to do that.
Do you also ever keep the gaps at 17 and go ahead clearing off them and expect them to be 18?
So with small deformities, I do, right? It's one of those things that as you do more of these, you see, okay, well that osteophyte's not that big. I expect that when I remove that osteophyte, it's going to open it up 1 millimeter or 2 millimeters. When you get the very large osteophytes, it's very hard to predict. So those are the ones that I do the mid-resection rebalance.
Thank you.
Yeah, any more questions? So if not, I think I have...
So can we end the day with one stupid question?
Oh no, there is no...
No
Dr. Ranawat
Okay.
says there is no stupid question.
So sir, basically...
The person is stupid if he doesn't ask the question.
That's right.
So in case of robotic THR, you said that the most common complication is periprosthetic fracture. And you said at the same time that the system is more precise. So what is the rationale behind the periprosthetic fracture? And is it more than the conventional in comparison to conventional THR, or it is in the robotic THR group?
No, right. So that's a great question. I think it's important to separate the two. So the risk of fracture is just a risk of using an uncemented femoral stem. So nothing to do with the robotic side of it, it's just using an uncemented femoral stem. And going to a triple taper collared stem has decreased that risk of periprosthetic fracture. What the robotic system has done is, number one, I think I'm faster doing the operation. Number two, I can do the impingement modeling, which has decreased the risk of dislocation. So I think the improvement in dislocation risk is from the robotic system, and the decrease in risk of fracture is because we've got a better stem that we're putting in. But they're independent.
So, but overall, like, have you done any study where you compared the conventional THR and versus robotic THR, the risk of, I mean, the number of periprosthetic fracture complication? I mean, which group it is more?
So exactly the same, right? Because,
Exactly the same.
Yeah, so we're not using the robotic system to put the femoral implant in, so it
Okay.
hasn't changed the risk of fracture. Now, one thing that's becoming quite popular in the United States are these pneumatic guns to broach femurs and to put femoral implants in, and we're going to have to wait and see if those increase the risk of fractures, because you're now pulling a trigger and there's a pneumatic gun that's hitting that implant in, rather than the feel of the surgeon with a mallet in their hand. We don't have data on that yet.
So we don't use robotic to do the femoral preparation.
Correct.
Okay.
The
So
robot-
5 years down the line, this is going to be, I think, the next topic we are going to study.
So no, I think that's a great question. If you look at the next generation of robotics, it's looking at how to prepare the femur as well.
And in that, I think we need to consider the bowing and everything, all that
Yep,
femoral anatomy.
So with this, you can see the planning of the femur. So you can see in 3 dimensions what implant fits into the femur, but it's not actually putting it in.
Okay, thank you, sir. Thanks a
Yep.
lot.
Okay, so if there are no more questions, I have one last question. Today whole day, Dr. Mayman, we spent on the knee preservation day. We were in this room and we were talking about like correcting 2 degree of varus of the tibia and 2 degree of valgus. And now we are talking about putting the knee in valgus or varus. So how does this knee preservation alignment relate to the alignment post TKR? Because this is something which I have always, thought, why an alignment has to be different even though there is some metal inside or it's a native knee. So do you have any thoughts on this?
Yeah, so I think that as we do knee replacements, we're getting closer to trying to reproduce normal knee anatomy, right? For 50 years, we didn't have precise tools. Same thing as you were talking about here with osteotomies, right? Osteotomies in the past were kind of cut the bone, look at it, and hopefully you're putting it back together correctly. Now I saw talks with all of these custom cutting guides to do very precise osteotomies. So now we've got precise tools to do knee replacements as well, so we can start aiming for things that are 2 degrees of varus, 3 degrees of varus, closer to the patient's native anatomy that we just couldn't do before with mechanical guides.
Knee preservation guys think of mechanical access as the gold standard, whereas the knee replacement surgeons think it's the CPAC where each knee is so different.
Yeah, but I think even the preservation, so people think of mechanical access in terms of the hip, knee, ankle alignment, but you've still got the joint line obliquity, right? And the CPAC is more, the CPAC is joint replacement surgeons' version of what preservation surgeons call joint line obliquity.
Oh, well said. On that note, I think let's end. That was a great